Industry Affairs at Siemens Healthcare. And now I'm going to turn it over to Charlene to begin.
Thank you very much, Lynn. Siemens is very proud to be able to offer our agenda for the meeting today, Newt Gingrich on health reform and ARRA. Our speakers today are former Speaker of the House and founder of the Center for Transformation, Newt Gingrich. Both Siemens and NextGen are pleased to be members of this organization whose focus is to improve quality and drive down the cost of health care, and we're pleased to participate with them in thinking through innovative ways to drive health transformation. In addition, Charlie Jarvis, Vice President of Government Relations and Health Reform from NextGen, will be joining me. NextGen and Siemens are partners in bringing together a fully comprehensive electronic health record. David Merritt will be our speaker, who's the Executive Vice President from the Director of National Health Policy from the Center of Health Transformation. Both Charlie and I work extensively with David in understanding what's happening on a national legislative as well as regulatory front on many of the health policy issues, especially in health reform. The Center has done extensive work in understanding the Affordable Care Act and its implications for the industry, and David will be speaking about that. So I think we've got a great roster of speakers, and again, we really appreciate the time that you've taken to join us for this webcast today. So what we'll see then today is the agenda. As we do routinely in these updates, we'll do a quick industry update, and then we'll move to the healthcare reform agenda, and then we will also have Newt join us to really step back and look at the broader landscape of what's happening, the elections, and politically as we navigate, if you will, the perfect storm. So if you look at slide, and Linda, this time on the perfect storm slide, usually what I do for the industry update is we kind of step back and actually look at the ARRA high-tech timeline. But today I thought we should perhaps step back and look at all of the initiatives that are facing the healthcare industry to really address the transformation that needs to happen. So this is sourced from a slide from the advisory board. And on this slide, you're going to see multiple initiatives from meaningful use, multiple stages, HIPAA, accountable care, remissions, hospital value purchasing, national episode bundling, et cetera, ICD-10. So as you can see, there is a myriad of change that faces our industry and that providers are working to respond to. So to that end, in recognition of that, and you can move to the next slide, Siemens and the Center collaborated in putting together a white paper which you have access to, and it's both electronic as well as in paper copy, that really asks some of the leaders in the healthcare industry how they're preparing for, if you will, the change that faces the industry and what they're doing. And this paper walks you through some of the questions that we ask some of the executives, such as what keeps them up at night, what has to go right, and some of those topics. And you'll see the providers also on this slide who responded to that, as well as some very specific initiatives they have in place. So we share this with you for the purpose of really giving you some ideas on strategies to address the perfect storm. And the focus here, not surprisingly, is around the use of health information technology as truly the lifeblood of navigating through this perfect storm. And certainly one of the quotes or one of the comments at the end is we recognize this industry is fraught with organic change. We've been fraught with organic change. But the bottom line is, and the seas are going to be rough, but rough seas do make for skillful sailors, and we offer this to you with that thought in mind. The next slide then represents the focus that both Siemens and NextGen working together have had to really bring together the interoperable health record to be able to really support the initiatives necessary for the transformation of care, including sharing data across the continuum, focusing interoperability in such a way to address patient quality of care as well as safety, recognize the need for information about the patient wherever the patient receives care, and importantly in all this process, we're driving up quality, but also we have to improve healthcare efficiencies, and we've got to find ways to to do that, and we're working with NextGen to do that. One of the areas important to the industry under ARR High-Tech has been certification, and I'm going to give you a little bit of an update on that. Siemens is very pleased to announce that all three of our product lines are now certified, and in addition, because of the fact that in health systems and hospitals, often they have Siemens as well as non-Siemens product, a mix of products to meet meaningful use. We're also offering various bundles of solutions so that the customers can, if you will, pick and choose those combinations that will lead them to meaningful use and to, hopefully, the incentive dollars. You'll find we're pleased to be able to operate. We're currently running a online online conference relative to ARRA and navigating from meaningful use to exceptional care. We offer that to you. In addition, if you go on our website, you can click and find more information about our certification process. And if you click on that comprehensive listing, next slide, what you're going to see is the detail of the elements that, the products are certified. So again, we're pleased to be able to announce the certification. So with that, I'd like to turn it over to Charlie Jarvis, and Charlie's going to give us a little bit of an update from the NextGen perspective, and then David's going to talk to us about healthcare reform.
Charlene, thank you very much, and good morning, ladies and gentlemen. We at NextGen Healthcare are very pleased to be partnering with Siemens for now going on 6 years, and are also pleased to be members of the Center for Health Transformation, and as Charlene mentioned, have been working very closely with Siemens and other colleagues within the center, working with Speaker Gingrich and Mr. Merritt on the development of national health policy across the country. We at NextGen Healthcare are also very committed, as Siemens is, to the development of meaningful use, particularly in stage 1. And I'm pleased to tell you that our offering, our ambulatory offering, which you see displayed on this particular slide here, has been certified. It's 5.6 SP1, has been certified by the Office of the National Coordinator's a temporary certifying body, and was actually one of the first products that was certified when the certification process was announced earlier this year. In our particular product, we are very pleased to be offering robust clinical content in 26 specialties, with more in development, that cover a variety of areas from internal medicine all the way through many of the subspecialties that we have long had in our product. Our knowledge-based module is an important component of the process, and that coupled with our health quality measures module, which will have 44 measures certified and available to be used by the beginning of the year, will offer all of our ambulatory clients, both those connected with Siemens as well as those in an independent status, able to pursue meaningful use at whatever point they wish to start that process during the course of this coming year. In addition to that, we are also offering, as part of our certified package, a patient portal, which is capable of not only meeting the first stages of meaningful use on the menu set, but is also able to be of great use to physicians in the ambulatory offices for secure messaging with their patients and allowing the patients to make appointments, pay bills, and eventually we'll move to much more aggressive patient-physician communications as we move into the latter stages of the process. As you can see on this particular slide, we are very pleased that over 500,000 patients of NextGen clients are already enrolled in this process, and we expect that to grow significantly as we get into the next year. So suffice it to say that NextGen, in coordination with Siemens, not only is offering a certified product, but will continue to be one of the industry-leading ambulatory solutions, and very, very proud to complement Siemens in terms of its process moving forward. At this point, I would like to turn things over to David Merritt. David is the Executive Vice President and Director of National Health Policy for the Center for Health Transformation, and David and Speaker Gingrich will be giving us some very important points regarding today's volatile and ever-changing market of healthcare reform. David?
Charlie, thank you very much, and thank you to Charlene and all of our friends at Siemens and NextGen for hosting this webcast. We've done this a number of times, and I think they do provide a terrific opportunity to not only present the latest and greatest in the industry and also from Capitol Hill, but also to hear from you what's happening out on the front lines of providing care. So I just want to reiterate my thanks to both Siemens and NextGen, and also really commend to you the paper that Siemens and the Center have put out today, Navigating the Perfect Storm. It really was a publication that looks through the lens of health reform and ARRA, and what hospitals and health systems are thinking. How are they going to comply? How are they going to transform? How are they going to actually deal with everything that's in the reform law, from new reporting requirements to reimbursement cuts to opportunities like many of the demonstrations that are out there. But what I'd like to do first is provide you just quickly with a recap. It wasn't too long ago when we were actually in this predicament, when we were having a very robust debate over health reform and the pros and cons of the policies that were making their way through the Congress. These were just, it's very, very raucous, got very, very passionate, because at the end of the day, when you're talking about health care, you're truly talking about life and death, and you're talking about quality of life, and that's why the debate was so intense, and from a quality perspective, but also from a budget perspective, you're talking about the largest sector of the economy, one that is continually growing for better or for worse. So the debate was certainly very, very raucous, but in the end, on March 23rd, 2010, the President signed health reform into law, all 2,700 pages. It was a significant political achievement for the President. It remains to be seen what price he will pay for it from a political perspective, because the polls still indicate that there is a level of discomfort and opposition. But for better or for worse, it's signed into law, and that's what everyone is dealing with now. So the lens you truly have to look at the future through is this. This is a resource we put together here at the Center over the summer, where we went through every single page of the legislation and pulled out every mandate, every requirement, every tax, every report, every commission, every grant, and all 500 of them, and put them onto an implementation timeline that stretches from the signing of the law through 2020. So this is a massive effort that CMS is going to be managing. And even just to give you an idea, like insurance exchanges are a huge part of this law. They represent one box on this implementation timeline. So there is just an enormous amount of work that's going to happen over the next 5 years. And you, as hospitals and health systems and providers, are truly going to be at the front line of trying to navigate this perfect storm, as Charlene indicated. So what I'd like to do is just quickly go through what we've actually covered as of now. We are about 8 months past the signing of the law. Many of the initial benefits have already come online. Medicare beneficiaries have received a $250 rebate check if they've hit the donut hole for Part D. There have been a couple of programs that HHS have already funded, one for early retirees and one for high-risk pools. Those are in conjunction with various states. About half actually ended up opting to participate in the high-risk pool program. About half did not. There is a question on whether that funding, $5 billion, is going to last long enough until 2014. That's when it's designed to last. And there are questions on whether that will actually last for that long, to ensure patients who have gone without coverage for at least 6 months. September 23rd was an important date. That was the 6-month anniversary of the signing of the law, and there were a number of changes to insurance and coverage that went online that day. The most important, or at least the one that received most of the press, was the top one, which was that dependents can actually stay on their parents' health plans until age 26. In the statute, they're actually referred to as adult children, though A friend of mine at the Chamber of Commerce refers to that as the slacker provision. There are a number of other insurance changes that came online on the 23rd. Rescissions, which are where insurance companies actually rescind a policy, even though there has been, when someone just starts filing a claim on a policy, some insurers, it's a very rare practice, but it does happen occasionally where a policy will be rescinded. That is now prohibited. There are also bans on lifetime coverage limits or caps and annual caps, which typically are about $1 million, and lifetime caps can be anywhere between $3 and $5 million. Those are now prohibited. And then insurers are barred from excluding children with pre-existing conditions up to the age of 19, and that has actually had an interesting market effect. There were a number of plans across the country that had child-only policies because, for the most part, children are fairly inexpensive to insure. But now that this pre-existing condition requirement is there, many insurers have actually gotten out of that market and no longer offer child-only policies, which obviously impacts kids who are trying to get, or parents who are trying to get insurance for their kids. They can typically go now through S-CHIP or go through their own coverage if they have it. But it does take away, and really was an unintended consequence, where it takes away an option for kids to get insurance. 2011 is obviously right around the corner, and one of the biggest changes to come online so far will be the medical loss ratio regulations for insurance companies and for payers. This was something that was a very, very intense debate. It started with the National Association of Insurance Commissioners at the state level. They have regulated the sale and purchase and administration of insurance. But as the federal government now moves into a more powerful role regulating it, it's now a dual partnership between the states and the federal government. And this was one where the states recommended to HHS a whole series of components that make up what is called medical loss ratio. That requires health plans to spend in the large group market, basically the large employer market, 85% of each premium dollar on medical services. So for every dollar they collect in premiums, they have to spend 85 cents of it on the actual delivery of care. The remaining 15% is reserved for what are called administrative items. So the debate has been very intense over what falls into which bucket, because if something falls into the 85% bucket, that means there are more things that can be defined in the 15% bucket. So the smaller bucket really does just limit basically what insurers can spend on administrative items, technology in many cases, unless it's directly related to patient care, salaries, overhead, marketing, association fees, many other what they term administrative components. Everything else is in larger buckets. So that definition has been very, very intense. That comes online in just a few weeks. The debate now is whether states will get a waiver to be exempted from that, or at least delay the implementation. There are about 10 states that have said they will apply for a waiver and 10 that have not. The first annual fee on an industry also comes online in a few weeks. This one on the pharmaceutical industry. There are a number of them that come online later on, which we'll go through. In 2012, 2012 is really gearing up for the big year, which is in 2014. So you'll see behind the scenes in 2011 and 2012, much of the work will actually be writing regulations and putting out rules that will affect what happens in 2014. So in 2012, it's still just working up to these later years. The most important one, I think, to note, at least in a long-term perspective, is the last bullet there on the CLASS Act. The CLASS program is a new federal long-term care program that will come online in 2012. It's a voluntary program that employers will actually opt into. Employees have the benefit of paying in for 5 years, basically vesting for 5 years, and then being able to file claims for federal long-term care benefits. The Deficit Commission that released a report late last week actually targeted the class program as something that is basically unsustainable in the long term. The same model is used in Social Security, where they collect more in they collect less in taxes than they pay out in benefits, and the Class Act has the same exact approach. So the Deficit Commission actually says it should be significantly reformed or repealed outright. Working up to 2013, again, this is getting progressively more intense as we work up to 2014, but in 2013 there is a new excise tax on the sale of medical devices. That's going to hit truly anything from MRI machines and imaging to diagnostic equipment to lab equipment and many other items. Typically, though, anything purchased at the retail level will be exempted. I believe it was up to $100 or so. Also, a tax on individuals earning $200,000 and above, or families earning $250,000 above, will see their Medicare payroll tax more than double. And this is to pay for what you will see coming online in 2014, which is really the big year for implementation. 2014, you'll see, is the first year for the individual mandate. This will be the first time that the federal government has required individuals to purchase a product or service. Now, there are many court cases that will be resolved between now and then on the validity and constitutionality of the individual mandate, but as of now, that law is on the books. That's the first year that companies with 50 or more employees will be basically required to offer what is deemed qualified health insurance to their employees. Now, it's not a mandate per se, like the individual mandate, but if an employer does not offer qualified coverage, they will be fined $2,000 for every employee they employ. So it's not necessarily a mandate, but certainly the penalty for not doing so is pretty significant. And I think that's one of the things that folks should really pay attention to over the next few years, is that companies will have already started, but will do so more in the future, calculating how much will we pay in a penalty versus how much will we pay for offering health insurance to our employees. If the penalty is substantially less than the cost that is typically incurred by providing health benefits, there are many employers who have indicated that they will actually opt to pay the penalty and then just subsidize through a direct deposit to a health savings account or some sort of subsidy for their employee to go out and get coverage on their own. That's something that we've seen already through some subpoenas and some hearings that the Democrats were going to hold in the House, where companies like Caterpillar and John Deere and Verizon are already doing those calculations. In fact, one of them was from AT&T that estimated they would save about $4 billion a year if they opted to pay the penalty. So that's something to absolutely watch. We'll see much more of those in the future. This is also the first year where federal subsidies are available. This is going to be determined by income, and it's a sliding scale up to 400% of the federal poverty level. So a family of four that earns about $90,000 a year would still be eligible for a small subsidy, but that will be the first year that you can get one. You will be able to use that subsidy through a state-based health insurance exchange. This is something that's actually heating up as we speak. States are determining whether they are going to build a state insurance exchange for individuals and small businesses to actually pool and find health insurance. These are something that the federal government will actually release a number of regulations over the next few years, but the states will be responsible for building them, and then after the first initial year of funding, the states will be responsible for actually sustaining them as well. In 2014 is also the first year that health plans can no longer exclude people from coverage if they have a pre-existing condition. As of now, some employer plans may be grandfathered from that exemption, but over time, the IRS estimates that upwards of 80% of businesses will lose that exemption. So you will see most health plans will be required to provide coverage to individuals regardless of health status and regardless of medical history. Over the next few years, you'll just see the mandates and the penalties increase, the taxes will increase. 2015 and 2016, you'll see Again, just increases to those two items. And 2017-2018, there's a new tax that comes online for employer-sponsored plans. These received a lot of debate, but there is so much time between now and then, I'm not sure that will actually come to pass. Now, one thing I'd like to quickly focus on, though, is even though the stimulus package and the health reform law were signed into law basically a year apart, there is a very clear tie-in between the two. And that's where many of the provisions in the health reform law relate to quality. And obviously, as Siemens and NextGen and many others will tell you, that in order to be as efficient as possible, in order to be as high performance as possible, you have to have health information technology. And I would actually argue for many of the quality provisions in the law, health IT is absolutely essential. Now, going roughly in chronological order, there's been a lot of talk recently about the creation of the Center for Medicare and Medicaid Innovation. Typically, demonstration projects and pilot projects have been run out of various divisions within CMS. They have created this innovation center to actually run all of the demonstrations and all of the pilots. So they will be testing new delivery models, such as patient-centered medical homes. They will be testing the demonstrations such as the Accountable Care Organization, the bundled payment pilot, and many others will be run out of this. So the head of it is actually a pretty impressive guy who used to be the head of Geisinger up in Pennsylvania, which has gotten a lot of attention over the last couple of years because of the quality of care they deliver at such low cost. In 2011, there'll also be a 10% bonus payment to primary care physicians. That's only a 2-year payment, though, 2-year bump up in payment. So that will sunset in 2013. There are also a number of value-based purchasing programs that are going to come online. These are demonstrations, again, that are going to be run out of this innovation center. The last bullet on this page is something that has gotten a lot of press and a lot of coverage because it could prove to be really one of the keys from the health reform law. This is the demonstration project for accountable care organizations. Now, everyone is familiar with capitation and the way that capitation worked with managed care, but this is a little different in that it is capitation in that an accountable care organization, which will typically be a health system or a physician group, will receive basically one payment of money. And if they deliver care that actually saves money, the system will be able to share in that savings. However, the difference between capitation and this approach is that there will be a very clear quality component. So they will have to hit certain quality measures in order to qualify for the savings. This will require, obviously, a high degree of health information technology. I don't believe it will be required, but it's certainly something that will allow an ACO to organize better and to actually coordinate care with many of the other community providers. So look for an interim final rule to come out in mid to late January over how that demonstration will actually be organized. But I know folks like Siemens, NextGen, and many other providers are actually looking very, very closely at that, as are we. In some of the out years, there are also, as Charlene actually mentioned in a previous slide, there are a number of reimbursement changes that will occur, two of which I have here, which are no longer reimbursing for preventable hospital readmissions beginning in 2012, and then not reimbursing hospitals for hospital-acquired conditions in 2014. Again, regulations are going to have to be issued as to define specifically what is a preventable hospital readmission, but you'll see something around, congestive heart failure and many other conditions where reimbursement will not be reimbursable. Also, as you see on 2013, CMS has long had up what's called Hospital Compare, where consumers can actually go on and find information on the performance, both quality and cost of hospitals across the country. There will be a site in 2013 that's called Physician Compare. And again, the regulations are yet to be written, but as the name indicates, this will be a portal for patients to actually get information down to the provider. I imagine they'll use a lot of the Medicare claims data to profile providers. So this is coming down the pike as well. And then the last bullet I'll point to is the Physician Quality Reporting Initiative. That's been up and running for a number of years. It's been a voluntary program up until now. Beginning in 2015, that is going to be required and for all physicians who participate in Medicare. So if you ask anyone how easy is it to report quality measures with a paper-based record versus an electronic record, again, the electronic record would win hands down. For all of these opportunities, for all of these requirements, again, health information technology is going to be something that is absolutely essential, and that's where the incentives that were in the stimulus law can be such a game changer. If they move more providers, more hospitals, more health systems, and physicians to adopt and meaningfully use an electronic health record and other information technology, it really will make dealing with the future, particularly as it relates to the health reform law, much, much easier. So with that, what I'd like to do is just set the stage for Speaker Gingrich to really give us an idea of what the future holds as far as health reform. A month ago, we had a tidal wave on the midterm elections that brought in Republican control of the House of Representatives. So certainly there will be changes on the Hill. They have indicated that health reform is in its gun sights, and they will go after that from a funding perspective and from an oversight perspective. But what do they offer as an alternative? So for some of these general questions and the lay of the land from the political landscape, I'd like to turn it over to Speaker Gingrich. Newt?
Yeah, thank you, David. And I want to thank Charlene and the entire team and Charlie at NextGen, so both the Siemens team and the NextGen team for getting us together. You know, you could hardly have had a better timing if you want to have a sense of how much things are changing in this city than to be having this conference call in the middle of sorting out the president's agreement to extend taxes for the next 2 years on everybody without raising any taxes, which has led to an explosion among Democrats in the House and Senate and is likely to be extraordinarily controversial in the left wing of his party, but also gives you some idea of the impact of last Friday's report that unemployment had gone up from 9.6 to 9.8%. And I believe this is also just the opening signal of how big changes in general are going to be. And so I was asked to talk about the larger framework, and I was just talking with Vincent Frakes, who many of you know has done our first two big charts, the wall chart, the 18-square-foot wall chart that illustrates the number of new offices created by the health bill, and then the 50-square-foot chart, which illustrates all the deadlines that are built into the bill out to 2020. And as you were hearing David talk you through some of them, just a slight touch of the complexity. One of our projects in the last couple of weeks has been, because the question was raised and the Secretary of Sebelius attacked me in the Wall Street Journal and suggested that I was exaggerating how much power she was given in the new bill. And so Vince has been going back and going through the bill in great detail. We believe we're going to show in a report that we'll issue a brand new chart probably in mid-January that will show that the Secretary is over 1,300 grants of authority and discretion in this bill, about 2.5 per page. Just a remarkable shift of power. And I was just meeting yesterday with some Washington representatives of major companies, one of who pointed out that the CMS and HHS are now moving towards bureaucratizing the entire process of applying health information technology in a way that this particular person thought would make it more expensive, slower, less likely to be practical, and would subject all the innovation around the country to more and more bureaucratic oversight and control. I think that what you're going to discover is that regulatory oversight is going to be one of the major themes of this new Congress. The collapse of the economy, the failure to create jobs and turn it around, the fact that we now have the longest period of more than 9% unemployment since the Great Depression. And the fact that, as somebody told me yesterday, they had just sat through a meeting with a group of economists in which the optimist said he thought that growth would be greater than people expected. And they said, fine, what do you think the unemployment rate will be in January of 2012? And he said, over 9%. And he was the optimist in the group. Faced with that, the friction of the kind of bureaucratic interference, and I have to confess, I was listening to David walk you through this, and when he said that congestive heart failure would not count as one of the appropriate uses that would be compensated, it raised the whole question of who wrote this bill and what were they trying to accomplish, and why would you in congressional language be singling out things like this when you know that the people writing the bill had no clue what it meant and had no idea what it would do to real people in real circumstances. So while I was listening to David, I asked Vince if he would draft a letter for me to Senator Baucus for his staff to simply ask about this one tiny thing. Why would they have put it in there? Why would they single it out? What's their rationale for turning this into law? This is the kind of detailed micromanagement of the largest sector of our economy by people who don't have a clue what they're doing that is going to turn out to be a disaster. Now, I'm giving you, this is my personal view, but it's also based on talking to a lot of people in a lot of places in the last 2 months. I believe you will see a major series of hearings starting probably in February, outlining how bad this bill is, how destructive it is, bringing in people to talk about all the different components that don't make any sense. And I think you'll see the House repeal the bill probably in April or May, and it will go to the Senate. And I don't think anybody has a clue right now what will happen at that point. Because the truth is, nobody would have guessed 6 weeks ago that the president would sign a 2-year extension of the current tax law for everybody. Nobody would have guessed 6 weeks ago that you'd have the kind of transition and authority up on Capitol Hill you're getting. And it's just beginning to sink in, I think, to the Obama White House that they are in extraordinary danger of being a one-term president. And so the question will become, how much are they willing to be flexible and how much are they willing to negotiate? And I think what Speaker-elect John Boehner and Republican leader Mitch McConnell just discovered is that these guys you can stare them down. That they went through a 2-week kabuki dance trying to find a way to get the Republicans to move off their position. And the Republicans just said no. And in fact, what they've done, which I must confess to all of you I find mystifying, is there was an opportunity to get a 3-year extension, which would have put the tax fight in the middle of 2013. Instead, for reasons that baffle me, they have made this a 2-year extension, guaranteeing that President Obama will be running in the middle of a huge tax fight in the fall of 2012. And that's just first of all, it's not good for the economy to have that short-term extension of the tax code because it makes it much harder for people to make the kind of investments you need for job creation. And second, it just guarantees he's going to be on the unpopular side of a huge fight over whether or not to raise taxes because the economy is still going to be weak. So I share that with you because I'm trying to paint a picture for you that the world isn't working out the way the left thought it would 6 months ago or 9 months ago. The things they thought would be popular are turning out not to be popular. The activities they thought would revive the economy have not revived the economy. They're about to collide with a Republican Senate leadership which will have gained 7 seats this year. And they're about to collide with a Republican speaker who is very well prepared, very professional, and who fully understands that his party just won the largest increase in the House since 1948. And John Boehner is going to be a very calm and very tough negotiator. So I don't think we know quite how this next phase is going to come out. I was talking with Senator Barrasso on Sunday about the fact that there are now going to be 4 medical personnel in the Republican Party in the Senate, almost 10% of the Republican senators, between Senator Coburn, Senator Barrasso, Senator Rand Paul, and Senator Bozeman from Arkansas. And so we've been talking with John Boehner's office about getting all the doctors on the Republican side together to talk about what is the right replacement policy because you can't just talk about repeal. You got to think about, okay, where do we want to go and what do we want to do? For example, here at the center, just as at Siemens, and I think it's fair to say with even more passion at NextGen, we're all committed to health information technology. So we want to think through how do we improve it, accelerate it, get it put in even faster, and how do we make it more doctor-centric. One of the great failures of public policy is it all stays up at some vague general macro level when life is actually lived at a micro level and people have to do implementation at a micro level. You'll hear us talk a lot more about that. And so that's a general background of where we are. And I think what might work best, Dave and Charlene and Charlie, is maybe toss it open and let people ask any of us that they want to questions about where we are.
Thank you, Newt and David and Charlie and Charlene. This is Peg Meadow from Siemens, and we have a series of questions coming in. I'm going to start with the first one for Newt. And the first question is, what is the single most effective action provider hospitals can take to influence the future of health information technology in Washington, D.C.?
Well, I think the most effective thing you can do is actually build an effective local model that is interoperable and that has both the doctors at the hospital and the other doctors in your community able to communicate with each other, as well as with the pharmacies and the nursing homes, so you create actually a community health information example for the country. I mean, what we really need, and this is a huge change from the way Congress has acted in the past, we need hearings on success stories. We need hearings on people who are actually getting it to work for real. We need to be able to bring in people that have thought through what do you have to do to so incentivize doctors and to so help them make the transition and to provide them with the certainty of service that enables them to be confident of the system so that doctors will adopt this and get to 100% adoption. I mean, as David said in his presentation, we are absolutely convinced at the center that you have to get to 100% electronic information flow in health, and that the faster we get there, the more lives we'll save and the more money we'll save. Part of that requires actually building models that will work. So I would say think community-wide. Don't just think of your hospital. Once you have a community-wide successful example, then start thinking about briefing your member of Congress, in fact, your entire state delegation, and think about briefing your 2 senators. And I think over the next 6 to 8 months, we could have some case studies coming in that could really help us move an understanding of what's needed. And you could then say, given your success, what does that teach us about the public policy implications of how we should change the way the federal government's operating in this area? We would be delighted. I mean, the center would like nothing more than to be able to host and coordinate with success stories and help those success stories get known nationwide and get known by policymakers in Washington.
Well, I would add that's one of the real reasons why we put together the publication that's being released today with Siemens called Navigating the Perfect Storm. I mean, we try and highlight what's really happening out in the real world, what technologies are being implemented and used, what new models of care are being used to actually bring down costs and improve quality. Taking those messages really to Capitol Hill and having policy written so it can allow the migration of those and adoption of those types of models be expanded dramatically is really the way it should work. Typically the way it works, unfortunately, is that you'll have policy written and then everyone else will have to fit into that box. So as Newt pointed out, taking success stories about what is actually happening in your district, in your state, and talking to both state and federal officials and just educating them on what you're doing, but also what the challenges are to actually expanding it even more, really is incredibly important.
David, while you're on the line, the next question that came in deals with what should the industry should expect in a quote, a stage 4 or stage 5 of ARA high tech and the future health IT initiatives as part of healthcare transformation. Would these be things we would see be effective in 2017 or in 2008 and 19?
Well, there certainly is a long way to go between now and then, and an incredible amount of work that needs to happen. I think generally the administration got it right the way they prioritized the funding. Basically, they have tried to get information technology into the hands of providers, regardless of if it's connected and interoperable with other parts of the system. As we've said, an electronic silo is better than a paper silo any day of the week. Now, the real promise, obviously, is when you have the ability to connect all of those providers and all of those systems so you can have information flow and care coordination and all the benefits that come from it. But actually getting to that level of interoperability is going to take an extraordinary amount of work. I don't think that HHS and ONC, the Office of the National Coordinator for Health IT, have provided the level of guidance and level of leadership that's really necessary at this point to give us a fairly clear idea of how to move forward. They've, I think, done a decent job with looking at some communities that have a level of success. We work with Inland Northwest out in Spokane. That's been an incredible example of sustainable health information exchange. The folks in Healthbridge in Cincinnati. I mean, there are a number of communities that have shown a lot of promise, and through the Beacon grant opportunities, the federal government, I think, is trying to highlight those and really try and learn from those, again, those success stories that are actually working out there, and then designing a national strategy that can emulate those success stories. You'll see, I think, in stage 2 and 3 of meaningful use, the direction will become clear. Because, you know, if you look out at 2014, 2015, they assume a level of interoperability that just isn't there today. So there is certainly a lot of working with folks like NextGen that has a very good interoperability community tool. I think that we can certainly get there, but it's going to take a heck of a lot of work.
Thank you, David. Another new question that came in this era of WikiLeaks, how safe will the privacy of medical records be in the hands of the Department of HHS? And I'll direct that to Newt or David.
Well, let me start, because I think this is a much larger public policy question. I have said consistently that, going back to the bill on genetic privacy, that I believe we're ultimately going to have to make hacking a felony, that it is a form of theft comparable to bank robbery, and it is a much greater danger to the country because it threatens the fragility of the whole system. On the WikiLeaks matter itself, I've taken a very hard-line position that the young man who leaked the 250,000 documents committed treason, that the system is scandalously incompetent. This is why I consistently talk about the need to outsource to American Express, MasterCard, and Visa, because the government systems are just so clumsy and so incompetent. Now, you have to ask yourself, how could a private have downloaded 250,000 documents and no expert system noticed it? And no expert system, after about document 20, said, gee, are you really authorized to download this many documents? I mean, this should be a radically bigger scandal than it is. It's an enormous disaster for the U.S. internationally. Why would any foreigner talk to an American official knowing that our systems are so incompetent that they could end up with their name published and they could be killed for having talked to us? So when you now apply that to health care, I think this is a huge blow. And it means that we had better have a serious national debate about cybersecurity. We had better be prepared to be ruthless and tough-minded about hackers. And we had better make the penalties for hacking extraordinarily high, just as the penalties for viruses should be extraordinarily high. These are attacks on society. These are not frivolous games. They are attacks on the very nature and integrity of an information age, and they're going to lead people to be cautious in ways that will cost us lives and cost us an enormous amount of money. So I'm very hard line on this. I think this is an area that we are being very foolish about not taking more aggressively across the whole society.
This question is more directed to you, and based on the comments that you made today, is there anything in the PPACA that should be kept in and they quote in a replacement type of health care reform plan?
Yeah, we've actually suggested at the center that we would love our members to identify for us those aspects that they think should be sustained. I mean, my advice would be to repeal the whole thing and then pass a bill implementing the parts that are good. Because I think if you get involved in trying to amend and modify this legislation, it just becomes a mess overnight. And I do think public demand for repealing it is going to go up every month as people see more and more examples of how it increases the cost, increases the bureaucracy, centralizes decisions in Washington among people who have no idea what they're doing. And that's not a partisan comment. That would be equally true if they were Republican bureaucrats trying to design 18% of the economy sitting in an office building near Pennsylvania Avenue. So I do think we'd like to identify parts of it. We were, the one thing I consistently supported in the stimulus, for example, was the money in there for health information technology. And so David may want to comment, but I think there are clearly things we would like to see continued, and we'd like to see legislation passed almost concurrently that would sustain the good parts of it. And frankly, would love the help of all of our members of the center identifying. But David, do you want to comment?
Sure. We've actually solicited ideas and suggestions from a number of different folks trying to identify those provisions that are quite good. In fact, a few of them that I'd mentioned, if you go back to the slides I had on the quality piece, I think the demonstrations around improving the quality of care, such as accountable care organizations, the bundled payment pilots, even the Innovation Center, if there's a way to better manage these kinds of demonstrations, I think is great. Many of the studies that are going to be put out, I think, are quite good. Many of the provisions around prevention and wellness are quite good. They do allow employers and payers more flexibility to incentivize employees and insured policyholders to actually focus on their health, and if they hit certain benchmarks, then they actually get upwards of 30% of their premiums can be reduced as an incentive payment. So there's also investments in public health. There's a prevention and public health fund that has received a lot of attention from Republicans as being wasteful spending, but if it's spent the right way, obviously education around prevention and wellness and circulating best practices and models of prevention and wellness that actually work, we think are a good thing. They could be administered at the state level and managed by governors, since each state has their own challenges and their own opportunities with their populations. So even something like that, the prevention and public health funding, could be, if retooled, could be a good thing. So there are a number of provisions that are worthwhile and I think can be effective. Where most of the fireworks occurred were on those bigger questions about insurance coverage. Should it be mandated? Should it be restricted? Or should it be much more flexible to allow consumers to find and shop for insurance? And we think it went in the wrong direction around insurance, but typically I think there's a lot of agreement and a lot of consensus around many of the quality provisions and the prevention and health, wellness provisions as well.
So we have time for one last question, and the question is, what kind of consolidation do you expect to see among hospital systems and healthcare providers over the next 3 to 5 years?
No, I expect to see a lot. This is news. I expect to see a lot because I think the cost of investing in the new technology and sustaining it, it's not the capital of the first purchase, but it's how do you have an IT system sophisticated enough to sustain it, gives a huge advantage to more sophisticated, more capital-intense operations, and makes it more difficult for solo practitioners. The only thing that might turn that around would be the rise of a Google-type service system that people could get for a very modest fee. And if somebody invents that in a way which is sustainable, then that would allow a fair amount of decentralization. Think of the difference between an IBM Walmart huge logistics system and the fact that FedEx and UPS make it possible for a very small business to have a remarkable worldwide logistics system. Right now we're in the phase where most of the advantages are for very large, sophisticated systems with full-time IT operators, and that gives them a huge advantage. Plus, the other thing that's going to drive this is anytime the government starts putting out huge volumes of regulations, a system big enough to pay for the lawyers has a huge advantage over systems too small to keep up with the regulations. It is an inherent anti-small business, anti-independent practitioner model when you start getting lots of government regulations that you got to keep up with. So all those things will be biased in favor of coming together, but the underlying nature of the information age may be to provide service providers on an autonomous basis so that you can be a fairly small practice because you've externalized all of your cost of operating onto a larger system that then aggregates its cost over very, very many clients. I'm not convinced yet which way it'll go. David is pretty convinced it's going to go towards more consolidation pretty rapidly. I think for smaller hospitals and for a lot of solo practitioner doctors, the pressure towards consolidation will be very substantial. But I want to let David also speak for himself on this.
Sure. Well, I think the pressures on the consolidation piece will be mostly coming from reimbursement. If you look at the hospital community and what they're going to be facing, particularly in 2014, the estimates for Medicaid expansion are upwards of 20 million new Medicaid beneficiaries. So they're going to go typically from uninsured to Medicaid. And as every provider will tell you, Medicaid reimbursement it doesn't even cover costs. Many times, in fact, I've heard Sarah Corley from NextGen say occasionally there were procedures that she wouldn't even bill for because it was too much work to actually submit the paperwork, and the reimbursement was so low it wasn't even worth it. When you have 20 million more beneficiaries coming in addition to all the cuts to Medicare that hospitals are going to face, upwards of $150 billion in reimbursement cuts, many small community hospitals just simply will not be able to withstand more patients and lower reimbursement. You could also look at some of the other industries. We've had conversations with small and medium-sized health insurers. With all the new restrictions around underwriting and premiums and rate review, in fact, just yesterday, Connecticut rejected a whole series of rate increases that Anthem was going to try and roll out for next year. They're basically going to have no premium increases, but their costs are going to go up. And for small and medium-sized health insurers that cover, maybe 5 or 10,000 or 50,000 lives, they're going to have a lot of trouble really complying with the law. And bigger insurers will look at this as an acquisition opportunity. We've seen the same thing happen in home health. There are about $40 billion worth of home health cuts through Medicare, and many of the bigger providers have said we can withstand it, but the smaller providers of home health services will not be able to survive. And so they're looking at the next 2 years really as an acquisition opportunity. So I think you'll see a number of things moving in the market around consolidation, but I think it's all going to be driven by the reimbursement cuts.
Thank you. Thank you to all our speakers. We do have a couple product questions that I wanted to let the audience know. We will direct to our Siemens product managers, and they'll get back to you on that. With that, I'm going to turn it back to Charlene to close out the webcast.
Thank you very much, Peg, and thank you, Newt, David, Charlie, for giving your time to participate today. I found it, again, as we look through the lens of and try and navigate this perfect storm, this is certainly an area where you have to peel the onion and you have to continually update yourself to understand the implications, because the change, the legislation is massive, the consequences of it, and even the unintended consequences are clearly we don't know those. So one of the key things that we've been really asking our customers to do, as well as our employees to do, is to stay abreast of topics, stay educated, become aware of it, and participate in providing their voice where they can to try and influence it, so that truly, as you suggest, those people who are in the trenches and see where we can drive up quality and reduce costs can put some real solutions on the table in terms of what really works. So again, we thank you all for participating. The last slide, as one of the things Siemens has been committed to is to bring thought leader level education as well as product education to the industry. We are featuring another webcast on the 14th about privacy and security. Again, I encourage you to attend that one, as this is another area where I don't think you can learn too much. Again, I reinforce we are doing right now the ARRA virtual conference series that's available to you, covering the legislation, interoperability, privacy and security, CPOE, and again provides a customer perspective on this. So again, you'll find that on our website. And then as we will with this one, we capture all of our webcasts and we make them available for your future use if you want to replay them. And again, they're very valuable as you're starting to move forward on the path of meaningful use and health reform, to come back and rethink a couple of these issues as you're navigating your road down to the changing landscape of health. So again, with that, I want to thank you today for participating on the webcast, and please join us in future ones.